Okay, hello, welcome everyone. I'm Chris Todd. I'm the Deputy Director of the NIHR Policy Research Unit in Healthy Aging, and I'm chairing today's session on what works to promote active aging, and it's reviewing the evidence for reducing inequalities in physical activity. We've got 3 talks today, 10 to 15 minutes each. First one's from Patience Kanunga, and she'll be telling us about promoting physical activity amongst disadvantaged and marginalised groups. And that's a rapid review of individual level interventions. Then we'll go on to Gemma Spears, who's going to talk about population level interventions to promote physical activity amongst disadvantaged groups. Another rapid systematic review. And then we move on to Laurie Davies, who's going to be talking about how the characterisation of the use of the General Practice Physical Activity Questionnaire, the GPPAQ, in primary care in England. So we have those 3 presentations, and at the end we'll have a time for questions and answers. Throughout the webinar, we're going to post links into the chat relating to any related research, so that can be looked at by you either, well, after the presentations, I should say. At the end of the presentations, we'll pause and provide an opportunity for questions and answers. Now then, you can put your questions up into the chat or into the Q&A option. I haven't on my machine because I'm using an iPad, but most of you should have a Q&A option up on the top part of your screen where you're able to post questions. You can also put a thumbs up in there if you like somebody else's question. And we'd like you to do that, because if there's a lot of questions and there's some of them more liked than others, we'll definitely go to those. However, we do know from experience that some firewalls stop you being able to use the question and answer function, the Q&A function. If you're unable to access the Q&A function, we suggest just use the chat function instead. That normally works. If you can't use the chat function either, we suggest maybe just rebooting your machine and trying again quickly. But we will endeavour to make sure that any questions posted either through Q&A or through chat get asked either during the session here or subsequent to that. We'll put answers up into the YouTube channel for later looking. We probably won't get to all the questions, but we'll try. Now then, before we go any further, I've got a couple of things I really want to say, because they permeate the 3 talks today. We know that physical activity gives lots of health and other benefits, functional benefits, as we grow older, and mental health benefits, so physical and mental health benefits from physical activity. However, we also know that as people age, their activity levels tend to drop, often falling quite short of recommendations set out by the CMO, Chief Medical Officer, or WHO. They're very similar levels. We also know that physical activity levels tend to be higher amongst people from higher socioeconomic groups. I mean, the more wealthy you are, the more likely you are to be active. In fact, the most wealthy are 4 times more active than the least wealthy. So this is a persistent finding that disadvantaged groups, marginalised groups, who often lack resources, are likely to be less active than the most advantaged groups. So we're really interested in making sure that whatever interventions we do close that gap between advantaged and disadvantaged by moving the disadvantaged up as much as possible, preferably without necessarily pushing even more the most advantaged groups. So that's one of the really important things in our seminar today. So that's sort of the background. Let's turn to Patience now, who's going to tell us about promoting physical activity amongst disadvantaged and marginalised groups at an individual level intervention. So if we could have your slides and get you going. Questions into the Q&A or chat function as we go along, please.
Okay. Thank you very much, Chris. Can you see my slides?
Yes.
Yeah.
Very clear to me.
Okay. So good afternoon, everyone. As Chris mentioned, I'm Patience Kanunga from the Policy Research Unit in Healthy Aging, based at Newcastle University. I'm going to share the key insights from our rapid review exploring how individual level interventions can support physical activity among disadvantaged and marginalized older adults. So the studies we included fell into two main categories. The first, we were what we call unselected or general population studies. These included older populations from a broad population, not chosen for a specific characteristic, but some did compare results across subgroups. So for example, looking at whether men and women or people with different income levels responded differently. The second were targeted studies, which focused entirely on a particular disadvantaged or marginalized group, such as focusing on low-income older adults or women or minoritized ethnic communities. So the key distinction between these two types of study is that the first one tells us about the risk of widening health inequalities, whereas the other type cannot. Therefore, we consider type A to be the most robust type of evidence, although both types are useful. So this review had three aims. First, we wanted to identify what individual level interventions have been used to promote physical activity among older adults. Second, we wanted to see whether these interventions work equally well for everyone, particularly people facing disadvantage or marginalization, such as those with lower income, lower education, or from minoritized ethnic groups. And lastly, we wanted to understand the lived experience, what helps people take part and what gets in the way and what makes interventions acceptable. So I'm not going to go into too much detail regarding the methods, but we conducted a rapid review using Cochrane guidance, focusing on studies published since 2015. We included 47 studies in evaluating individual level interventions, either across general older populations with subgroup analyses or targeting specific disadvantaged or marginalized groups. And we used the Progress Plus framework, which you can see around here, that lists the factors that we were considering. So for data synthesis, we grouped interventions into four broad categories, which were physical activity, behavioral, interventional, and multi-component interventions. So first, the physical activity interventions included interventions such as structured exercise or dance classes and programs asking participants to complete specific activities at set times or intensities. The behavioral interventions were interventions that use techniques like behavior change, for example, goal setting support, social support, or activity tracking to help people sustain activity over time. Third, educational interventions, for example, those that focus on increasing knowledge and awareness about physical activity through lectures, workshops, or printed information. And finally, multi-component interventions. These are interventions that combine two or more of the elements that I've talked about just now. For example, mixing exercise classes that include motivational goal setting or peer support. So most studies we identified were multi-component or physical activity based, suggesting that combined approaches are more commonly evaluated in this field. So this table summarizes the evidence we found mapped against the Progress Plus framework. And as you can see from the last column, most studies were conducted within specific disadvantaged or marginalized groups, such as women, people from minoritized ethnic communities, rural populations, and those from low incomes. And in contrast, you can see here from the third column that it shows that very few studies involve general older populations that analyze results separately for disadvantaged subgroups. So we know little about whether interventions worked equally well across social groups. Most of the evidence came from the United States, with only a few studies from the UK, and these largely focused on socioeconomic disadvantage. While there's valuable evidence on what works within particular groups, we can't be certain that these interventions would reduce rather than widen inequalities if applied more broadly. So I'll come to the results now. So the findings from general older adults, the ad selected with subgroup analysis. As I mentioned earlier, we found very few studies in general older adult populations that compared how effective these interventions were across different social groups. So as you can see from the table, only 2 Progress Plus factors were represented here. So you've got education and gender. And across both, the evidence was very low. Certainty was it was of low or very low certainty, as you can see in the table there. So we can't be confident in the results. As shown in the first data row for education, there were just 2 studies and neither showed any significant differences between people with higher or lower educational levels. For gender, there were 6 studies, but the findings were mixed. Physical activity programs tended to work better for women than for men. But the evidence isn't strong enough to draw firm conclusions. Behavioral interventions showed variable results, while multi-component interventions were generally not effective. So that you can see that from this table here. So we also identified just 1 study that looked at differences within an already disadvantaged population. And in this case, it was a sample of women only. The study compared outcomes by educational level, marital status, and ethnicity, but found no significant effects of the physical activity intervention across any of these subgroups. So because this evidence was rated as very low certainty, we can't be confident in the results, no behavioral, educational, or multi-component interventions included this kind of subgroup analysis. As you can see here, we had no studies at all. So overall, we can say there's almost no evidence examining how interventions perform across different forms of disadvantage with marginalized populations. For example, how gender and ethnicity or income might interact to shape outcomes. Most of the studies we identified were conducted within disadvantaged or marginalized groups, rather than comparing them to the general population. So we found studies across 4 categories, which were low socioeconomic status, you can see in the first row, minoritized ethnic groups, rural residents, and women-only samples. Among those with low socioeconomic status in the first data row there, physical activity, behavioral, educational, and multi-component were shown to be effective. They were all shown to be effective, but the evidence was based on a few small studies, including 2 from the UK, and rated as very low certainty. For minoritized ethnic groups, findings were more moderate. They were moderate certainty, showing that physical activity and multi-component interventions, particularly culturally tailored ones, can increase activity levels. However, all studies were conducted outside the UK. For rural populations, in our third row, both physical activity and multi-component interventions appeared effective, but again, the evidence was low certainty, very low certainty, sorry. Overall, the strongest evidence came from studies in minoritized ethnic groups, suggesting that culturally tailored interventions can be effective, though evidence from the UK remains limited. So I'm going to move on to our qualitative findings. So the synthesis highlights what matters most for encouraging physical activity among disadvantaged older adults. First, social support through groups, peers, or mentors consistently emerged as a key motivator for ongoing engagement. Second, tailoring interventions to people's individual and cultural context was crucial. Participants were more likely to take part when programs reflected their lives, values, and preferences. Third, we need to tackle the structural barriers, for example, costs, transport challenges, and for women in particular, caregiving responsibilities. These are some of the factors that make participation difficult. Embedding activity into daily routines, such as through community hubs or social local initiatives, can make it more sustainable. Finally, more equity-focused research is needed, especially around intersecting forms of marginalization, gender-sensitive design, and how best to support participation among the UK's diverse minoritized ethnic groups. The overarching message is that successful interventions are social, local, and tailored. They're designed with communities, not just delivered to them. So to conclude, we found limited evidence on what works to increase physical activity or reduce sedentary behavior among disadvantaged and marginalized older adults in the UK. There's a critical evidence gap. Very few studies compared outcomes across social groups, so we can't yet tell whether interventions are reducing or reinforcing inequalities. However, the studies involving minoritized ethnic groups offer valuable insight. So programs that are group-based, motivational, and culturally tailored appear most promising. The key takeaway for policy is that interventions need to be designed with equity in mind from the start. Thank you very much.
Thank you, Patience.
Yep.
As I said before, we won't be taking questions at this point, although I'm hoping that questions are in the chat. But we'll move straight on to Gemma, who will tell us about population level interventions rather than individual level. Thank you very much, Patience. Well delivered. Excellent presentation.
Thanks, Chris. Thanks,
Gemma.
Patience. I'm just waiting for my slides to load. Everyone see these slides?
Yep, that's great.
Fantastic. Thank you. Hi everyone, I'm Gemma. I'm a Principal Research Associate within the Healthy Ageing Policy Research Unit, and I'm going to talk through the second of the 2 reviews that we've done this year on physical activity. Right, bear with me. I'm having problems flicking to my next slide. Here we are. So in addition to looking at evidence about interventions targeting individuals and small groups, we wanted to look at what might be working to promote physical activity among disadvantaged groups at a population level. And when we talk about population level interventions, what we mean are those wide-scale approaches that target the social determinants of health and which are geared towards whole communities in defined local, regional and national areas. There are lots of different types of population level interventions to improve health, and for this work we used a common framework that defines 3 broad approaches. These include behavioural and social approaches, which modify social environments or enhance behavioural management skills to enable changes in lifestyles in large group settings. Information and campaign approaches, which aim to enhance knowledge and modify attitudes, and environmental and policy approaches. So environmental approaches aim to improve the accessibility, safety and desirability of physical environments and community infrastructures. And policy approaches do pretty much what they say on the tin. They reflect changes to local, regional or national policies that impact whole communities and populations. So we undertook a rapid review this summer to look at evidence for these sorts of population level approaches. We included any evaluation of a population level intervention which looked at the impact on any measure of physical activity or a process evaluation outcome such as the acceptability of an intervention. Eligible interventions did not need to be designed with the express aim of promoting physical activity, but physical activity did need to be evaluated as an outcome to be included in our review. We also only included studies where the effectiveness of the intervention was reported by levels of socioeconomic status. We did this so that we could make a judgment about whether the intervention works in disadvantaged groups and whether any demonstrated benefits of the intervention differed between the most and least advantaged populations. So in the review that Patience has just described, we looked at a range of dimensions of disadvantage, but in this review we only looked at socioeconomic disadvantage. So we didn't consider, for example, effectiveness by gender or ethnicity. And this was partly a pragmatic decision so that we could offer a timely piece of work, and we wanted to look at a dimension of disadvantage that would have the biggest policy impact, but also partly because our scoping indicated that most of the evidence about population approaches tended to consider socioeconomic disadvantage when thinking about equity. And as with the work that Patience has just described, we limited our evidence to publications from 2015 to avoid duplicating previous work. So I'm not going to bore you with the finer details, but we used standard, robust, rapid review methods, including a quality appraisal and narrative synthesis. So what did we find? These are the studies and the population interventions that we identified in the literature. There was the introduction of the minimum wage in Germany, which was not designed to impact physical activity, but this study did evaluate the consequences of the policy for physical activity. There were studies evaluating the introduction of cycling and walking routes in the UK, and there were 2 community-wide health promotion campaigns in Japan, each targeting slightly different demographics. The intervention in the Sato study targeted primarily people aged 65 years and over in the city of Fujisawa, and the intervention evaluated by Suzuki et al. Targeted adults primarily aged 40 to 79 years in the city of Annan. There were 2 interventions which focused on changes to the environment beyond cycling and walking routes. So one was a greenscape type intervention, the core component of which was the introduction of a playscape in a park for children, but the impact on adults was evaluated. And one was referred to as a planned walkable neighbourhood in the US, but it went beyond walking routes and it included changes to the wider environment, including consideration of neighbourhood aesthetics to improve physical activity. There was an evaluation of 2 investments from Sports Australia, and these investments were to support local localities to implement their own programs to promote physical activity. But this evaluation is of the investment only. It's not an evaluation of the community programs that resulted from the investment. And finally, there were 2 interventions that were based on free access to leisure facilities in the UK. One which took place in Blackburn with Darwin, which also included community outreach events and health promotion components, and one in Leeds, which included a media campaign to promote awareness of the free facilities. So you'll see on this slide that I've highlighted 3 studies on this table. These are the best rated in terms of our quality assessment. All 3 were rated moderate in quality. So these 3 studies used controlled before and after designs with strong analytical approaches. So they were decent studies, but they were rated moderate because of some other methodological issues that could have introduced bias. The remainder were rated low in quality, which means that none of the studies were rated high in quality. So in the next few slides, I'm going to tell you what we found from this body of evidence, and I'm focusing on 2 particular questions. First, did the intervention increase physical activity in the most disadvantaged groups? And second, what sort of risk does the intervention pose to widening health inequalities? And to answer this second question, we looked at whether any of the observable benefits of the intervention were greater in the most advantaged groups compared to the most disadvantaged groups. So the 2 most promising interventions were the free access to leisure facilities coupled with community health promotion components in Blackburn with Darwin, evaluated by Higginson et al., and the community-wide health campaign targeting older adults, evaluated by Sato et al. Both of these interventions increased physical activity in the most disadvantaged, and these benefits were larger in the most disadvantaged groups compared to the most advantaged groups. So we can make a judgment that these interventions might pose a low risk of widening health inequalities. The evidence about cycling and walking interventions, or cycling and walking route interventions, give a bit of a mixed picture. So first, increases in cycling favoured the more advantaged groups. However, the impact on walking looked a little bit different. There were a range of different walking outcomes evaluated across these studies, and for some of these walking outcomes, not all of them, the benefits were slightly larger in disadvantaged groups. So for example, in one study, the take-up of walking favoured the most advantaged, but sustained benefits in walking favoured the most disadvantaged. And then another layer of complexity with this evidence on cycling and walking routes is that this pattern was observed on some but not all measures of socioeconomic status. So our interpretation here is cautious. Cycling and walking route interventions might be promising in terms of boosting walking in the most disadvantaged groups, but the evidence isn't conclusive. And a little bit later, I'll talk about what might need to be considered in relation to these approaches. For the second community-wide health promotion campaign intervention in Japan, the Sports Australia investment and the planned walkable neighbourhood in the US, we judged these interventions to pose a high risk of widening health inequalities. So whilst the community health promotion campaign approach in Japan did increase physical activity among disadvantaged groups, the benefits were larger for the more advantaged populations. And because of the way the data were reported in the US study, we could only really tell that physical activity increased more so for the most advantaged groups following the planned neighbourhood intervention. And in the Australian study of the sports programme investment, there was a slightly mixed pattern of findings for one funding stream. For the funding stream targeting sports for older people, this was linked to a reduction in physical activity, and this reduction was larger for the most disadvantaged, which was why we've made a judgment here that the risk to health inequalities, to widening health inequalities, is potentially high. And finally, we have these three interventions. So only the free leisure intervention in Leeds was linked to an increase in physical activity among the disadvantaged, but the overall pattern of data as it was reported meant that we were unable to make a judgment on the risk posed to health inequalities. The minimum wage in Germany was linked to a reduction in physical activity, whilst the findings for the park refurbishment were too inconsistent to get a clear picture of impact. And we didn't find any eligible studies that reported process evaluation outcomes. So what can we take from all of this? I'm going to finish this presentation by talking through three key implications coming from this evidence and what we might think about in relation to policy developments in this space. So first, although there were two interventions that appeared to work well in promoting physical activity in disadvantaged groups, whilst also posing a low risk of widening health inequalities, there is the question of how well these would work elsewhere under different contexts and with different populations. Obviously, at this population level, contexts and populations do vary, so what works in one place might not necessarily work elsewhere. So I guess the key takeaway here is that if adapting and adopting these approaches in other contexts, ongoing monitoring and evaluation is absolutely critical. And obviously, a big part of that is not just asking, does it work, but asking, does it work for everyone, including the most disadvantaged? A second take on this evidence is that it reaffirms the importance of low-cost options to promote physical activity among disadvantaged groups. We see that with the free leisure facility intervention, but also potentially the cycling and walking route interventions. So it was interesting that in the cycling and walking route evidence, the initial take-up of walking and cycling favour the more advantaged, but longer-term benefits than walking favour the more disadvantaged, which might suggest that there needs to be some mitigation in place to those initial cost barriers associated with the take-up in order to maximise take-up by those who might be struggling financially. And then a final take on this evidence is that many of the population approaches found in this review would inevitably encourage physical activity outdoors. So an important consideration for policy here is how to ensure that these approaches are inclusive of people who may struggle with outdoor mobility or who may have safety concerns around exercising and moving around outdoors. So I am conscious that I've whizzed through these findings and I've omitted some useful details for this short presentation slot. There is a lot more nuance to these findings and I've been able to convey here, so please do watch out for the full publication if you'd like a more in-depth picture of this evidence. And we also have a short briefing available which will be on the website soon. So thanks for your attention and I'm happy to take any questions a bit later.
Thanks very much, Gemma, for another very clear, excellent presentation. At least in
Thanks,
my
Chris.
mind. Thank you. And third, I'd like to turn to Laurie Davies.
Thanks, Chris.
And Laurie's going to be telling us about characterising the use of the general practice physical activity questionnaire in primary care in England. So work on the GPPAQ. So Thank you very much, Laurie. I'll hand over to you to take us away.
Okay, great. Thanks. Can you see my slides?
That's perfect, yes.
Okay, so thanks everyone. So as Chris just said, this is our third presentation, which will be characterising the use of the General Practice Physical Activity Questionnaire in English Primary Care. And this was a project, a joint project with the Healthy Weight Policy Research Unit as well. So in terms of a brief background, the General Practice Physical Activity Questionnaire, or GPPAQ, is the current assessment tool for physical inactivity, but little is known about its current use. So with that in mind, we aim to investigate how the GPPAQ is being used in routine general practice, and we had three aims, which were to examine the characteristics of patients who have and have not completed the GPPAQ, its routine use, including timing, repeated use, and with which staff groups, and finally, whether completion of the GPPAQ is associated with a subsequent offer of physical activity related interventions or advice. And we achieved these aims by using descriptive statistics in the Clinical Practice Research Data Link, which is a large and well-regarded database of anonymised patient records from general practices in England. And with this dataset, we constructed two samples. So firstly, to provide a comparison group from the general population, we do a random sample of approximately 1 million adults without date restrictions. And then secondly, we do a sample of approximately 1.78 million adults who had at least one GPPAQ recorded in the past 5 years in order to provide a deeper dive in a larger sample who had relatively current use of the GPPAQ. And for each question in our aims, we generated complete data for the variables of interest. So in terms of the random sample results, almost 1 in 10 of these participants had a GPPAQ recorded. Their mean age at first use was 55 years. A small majority were women, and in terms of health conditions, the GPPAQ was mostly completed in people with a history of pre-diabetes or being overweight. And just to make a minor point on terminology, the term pre-diabetes has now changed to non-diabetic hyperglycemia. So it's possible that results may change using this more recent term, but the key point is that having high blood sugar or being overweight appear to be prompts for using the GPPAQ. Then turning to the larger sample results, approximately 4% of these participants had the GPPAQ recorded. Almost half were repeat recordings, but there was little evidence to suggest regular completion of the GPPAQ. Most GPPAQ recordings were from patients aged between 40 and 74 years, and a small majority were from female patients. In terms of monitoring, almost half of patients had a GPPAQ recorded on the same date as a cardiovascular health check. Around a fifth had it recorded on the same date as an NHS health check, but the GPPAQ was rarely recorded on the same date as new patient appointments. In terms of health conditions, in this larger sample, the GPPAQ was mostly completed by patients with a history of diabetes, low back pain, cancer, or hypertension. This is different to our random sample results, where being overweight or non-diabetic hyperglycemia were the main recorded conditions. And this is likely to be down to differences in our sample selection. So, for example, because the larger sample group was selected on the basis of having a GPPAQ in the past 5 years, it's more likely to have picked up regular primary care attenders and therefore monitoring for long-term conditions, whereas because the random sample group was selected without any date restrictions, it's more likely to have picked up opportunistic GPPAQ recordings, but this hypothesis will be investigated in a further analysis where we'll also look at BMI and deprivation. And in terms of staff groups, the GPPAQ was mostly completed by healthcare assistant and nurse contact roles, but rarely by general practitioners. And this fits with the existing literature in terms of the time pressures on GPs, for example, and healthcare assistants and nurses having a large role in preventative care. And then finally, in terms of physical activity related interventions or advice, the GPPAQ was followed by such interventions in around 60% of cases. So in summary, the GPPAQ appears to be used with some of the intended target age group and is often followed by intervention. Its use may be prompted by a diagnosis of being overweight or non-diabetic hyperglycemia, but much of its use is in monitoring consultations for long-term conditions. And as just mentioned, the GPPAQ is most often used by healthcare assistant and nurse contact roles. Thank you for listening.
Thank you very much, Laurie, for another very clear and well presented presentation. We have some time for questions. I unfortunately am unable to see the chat. That's actually where the questions and answers Q&A session is. So I'll have to ask one of my colleagues to tell me what's in the QA section. I can see the chat, and I've seen there's one question from Lindsay Kramer about for patients, and this is: was the qualitative research designed with or co-produced with the research group, and who were the qualitative group? Maybe patients, shall I answer that, because I know the answers?
Yes, sure, Chris.
Yeah, you'd be happy.
Yeah.
Thanks. It's an interesting question. It's an important question, of course, because co-designed interventions are likely to actually pick up on what the target individuals, target population are likely to want. So it's an important issue. Don't forget, this was a systematic review, a rapid review of literature. So we're just reporting what was reported in the papers. And so were the interventions designed based on interviews, qualitative work with the target individual groups? That's mixed. Some were, some weren't. There were 47 studies in this review. 38 of them report on effectiveness and have sort of basically transitioned into what's being talked about today. So some were designed with the target group and some were not. And who were the qualitative group that was interviewed? Again, it depends upon the paper. So what we've done is we've drawn out the qualitative results from each of the papers, and then we've synthesized it into that overview that patients gave us. In the report and in future publications, we would expect to give more detail on that. But the qualitative groups were dependent upon, some of them were men versus women, some of them were ethnic minority groups, especially in the American studies. They were ethnic minority groups, which were maybe different to what we would normally expect to see in the UK. So there was quite a lot on Hispanic Americans who were interviewed. So a group we wouldn't necessarily, and there was nothing on, for example, South Asian groups in America. So quite different groups to what we might see in this country. Here's a question, and this one's for you, Laurie, I think. It's about the GPPAQ, and is it valid for use amongst older people? Is the question?
Yeah, and it's only valid for people up to 74 years of age. I believe there are ongoing discussions about its application in older people, such as whether like walking should be added to it in this age group. But that was kind of beyond the scope of this work for us to look at.
Yeah, thank you. Yeah, it's quite right. It actually is the subject of further work we're doing with Healthy Weight Policy Research Unit on the use of the GPPAQ, looking at validity and reliability of the instruments. And from Caroline Birch as a question, again for you, Laurie, what were the interventions included?
So some were quite non-specific, such as the code just said lifestyle intervention, advice or something like that. Others were things like referred to exercise group or weight loss intervention, that sort of thing. Though a limitation of our work is that we can't comment on whether people were offered lifestyle advice in the consultation, such as advice to go swimming, but these may not have been recorded as read codes.
Because it's completely dependent on what the read code, what codes are entered into their records. Yeah, so we're dependent on that being done properly to know what happens next. A question for Gemma, actually, now, again from Lindsay, about were the trials randomized and what kind of designs were included? Were they quantitative and qualitative designs, or whichever? So if you'd like to just talk us through designs of the studies.
Yeah, I have popped an answer in the Q&A, but I'll talk through it. We were open to both quantitative and qualitative designs, but the studies that we found that were eligible and met our criteria were only quantitative. None of them were randomised. We did say that we would take any quantitative design, whether it was a randomised step wedge or cluster trial, or before and after, or a controlled before and after, but we only found controlled before and afters without control groups, so no randomised studies.
I think this one goes to all of us, really. Have we got any comments from David Leet? Have we any comments on the issue of sustainability of these interventions? Because effective interventions may not be easily sustained. So are they sustainable because of the cost or staffing or policy issues or the social context? So
I could start on this because this is a question that I had when I was thinking about some of the interventions that were considered both effective and equitable in the population review. So one of them was a free facilities, and I was actually thinking about my own local leisure centre, which has been threatened with closure consistently over the past 2 years, and I was thinking about this issue of sustainability. I don't have an answer for you, David, but I do think that this would make a very interesting qualitative study with local leads and policy leads to think about how sustainable do you think these approaches might be, and what sort of pressures might you have to tackle in order to maintain these approaches. That's my reflection.
It's very difficult to answer, isn't it? And of course, we don't know how sustainable the funding of different interventions is. And I was at a presentation only yesterday, which was talking about an effective strength and balance class and how it had been run for years and then suddenly it's no longer commissioned, just disappears. And it's difficult to know how long these things can last for. Would any of the other speakers like to comment? Sustainability?
Yeah, I don't mind to comment on that. Yeah, so I agree that this is quite difficult. So I think effective interventions often require resource-intense delivery models that are difficult to maintain outside research context, particularly in under-resourced settings. So future evaluations should consider sustainability. At the moment, we cannot answer that yet.
Thank you. I'll just say something else, because sustainability has a number of components, doesn't it? We often think about uptake of an intervention. Do people actually start it? And then we tend to talk about adherence to an intervention. Do people carry on doing it in the long term? And so I think quite a number of these activity-related interventions, if done well and built in with psychological components, can have long-term adherence, or do have long-term adherence. The problem quite often is that some of these interventions, you have 24-week intervention, for example, and then the funding stops, and it's very hard for even the most adherent older person to carry on doing the intervention if they haven't got the resources. And though that's the sort of issue that we face, particularly with a marginalised group. So I think very much build into the interventions methods to make sure that there is long-term adherence by the people taking part, but we also have to think about the long-term, I guess, sustainability of the funding mechanisms. Right, funding's crucial. Yeah, Viola, Ricardo, great, thank you. Individual interventions seem largely based around exercise and has access issues. Is there any scope to consider even more personalised self-management interventions, and how efficacy, let's call it effectiveness, might differ in underserved groups, and how this could be sustained? So can we, rather than having necessarily face-to-face exercise interventions in groups, I'm assuming is what Rihanna is saying, are there other mechanisms for doing this? And I'm guessing you're thinking in terms of technologies. And I'll just answer for, if I may, patients, to other work that we've been conducting within the group, which does look at the use of apps and technology. There's quite a lot of evidence now to show that you can get long-term sustainable interventions for physical activity promotion using apps and other digital approaches with certain groups of people who are able to access the apps and have the access to the technology. And that may be, because of the digital divide, a real issue here for people from marginalised and disadvantaged groups. So yes, I think there are ways of doing it. No, I think there are going to be problems in policy terms unless we can make sure that we don't exacerbate the differences between the better off and the less well off, which technology still tends to be doing. Okay, right, I'm going to have to come to an end in a moment. A reflection here on the intervention, one size fits all and not necessarily what the individual wants. Yep, that's quite true. Yeah, and I think there's a couple of comments about sustainability here for strength and balance classes and whether they're paid for by participants. But of course, paying for by participants will be to the advantage of the most advantaged groups and would actually be a barrier for the more disadvantaged groups. So I think we have to be very careful and think about the long term, how we ensure that we don't exacerbate health inequalities by asking people to pay for things. And I think that Gemma's presentation with the free access to leisure services is a great policy initiative if we want to really help reduce inequalities between disadvantaged and advantaged groups in taking up activity in the long term. I'm going to draw it to an end now. I'm getting prompts from within the chat to remind everybody that we have our next webinar on the Wednesday, the 19th of November at the same time, 12 o'clock. And that webinar is going to be on shaping the future for brain health, dementia prevention and future care needs. And it's going to include quality and measurement issues in that webinar. Thanks everyone for coming. I hope it's been useful and for engaging and asking questions. Thank you to all three speakers for great presentations. And I also want to thank Linda, Anusha and Jane for all the hard work that goes on behind the scenes for making these webinars happen and the rest of the team. So Thank you everyone for making this webinar such a success. Great to see, I think it was 86 people in the room at one point. And hopefully you'll be able to come to the next of our seminars next month. Thanks very much, and bye-bye everyone.